Welcome back to the How I Rehab podcast, brought to you by the SportsMap Network. Thanks for joining us. Super excited about the guest we have on today in Ernest Schilders. Ernest is a specialist, orthopaedic specialist out of London, where he works a lot in minimally invasive hip surgery and has a unique professional portfolio combining his expertise in this area and hamstring problems. He's the go-to surgeon when it comes to your top athletes in the UK from EPL and other sports. And some of his key discoveries was around the existence of the PLAC complex, or the pyramidialis muscle. And that's revolutionised the way some elements of groin pain is managed. And we'll tap into this area today, as well as the very topical Junction when it comes to any surgical intervention that might be required for this pathology. Before we jump forward into that, I'll just remind our listeners about our really exclusive events coming up, and that's the hamstring event in northern Italy, which is late June. There's only around 10 spots left for that now. Lots of top professional sporting teams, attending, and it's going to be a really high-level workshop. So can't wait for that. But get in quick if you're keen for that. And we're heading to India for those from the subcontinent around late August, 23rd of August, for the How I Rehab Sports Injury Conference. We've got some great presenters from Aspetar, as well as Australian cricket, and some top-level sporting physios from in and around India. So that's going to be super fun and a high-level workshop-based event as well. Now, it is also the double masterclass month across the SportsMap platform, whereby Tim Roberts' masterclass is coming out around the management of the combat sport athlete. Tim works in UFC. And Dr. Adam Castrigan is talking to bone stress injuries in the lower limb. So two amazing topics. And also we have Rowena Johnson around imaging the groin pain coming in the coming months, and that gets mentioned here. Rowena works closely with Ernest, so a really nice way to combine the two topics. Also recommend listening to our last podcast around T-junction injuries with Fergal Kieran, and it has some nice crossover in today's chat with Ernest. Welcome, Ernest, to the How I Rehab podcast. Absolute pleasure to have you on.
Nice to be here. All down under.
Yes. Now, mate, for those that don't know much about your work, obviously we were chatting before, I think some of the work in the groin space around the PLAC and what you're doing there has been really pivotal. And I know you're a highly sought after surgeon in the UK for some of the top athletes. So today we're going to talk around some management of the groin piece and hamstrings. But as I said, for those that don't know you, can you give us a bit of a rundown on you and what you're doing at the moment in your career?
Yeah, of course. Hello and welcome. So I'm Professor Ernest Schilders. I'm an orthopaedic surgeon. I work in London at the Ford's Clinic in the Wellington Hospital, but I also hold an academic role as a professor of orthopedic sports medicine at the School of Sport at Leeds Beckett University. My clinical research, my clinical and research focus is on minimally invasive treatment of hip and groin injuries, with particular expertise in hamstring injuries, complex groin pain, and hip arthroscopy. And I've had over the years the privilege of treating elite athletes from Premiership, Champions League, and a wide range of professional sports such as rugby, tennis, ice hockey, basketball, and also cricket. So a core aspect of my work is an anatomy-driven approach to both diagnosis and treatment, with a strong emphasis on the understanding of the anatomical and biomechanical cause of groin pain. And I have a particular interest in inguinal adductor and also the nerve anatomy. So the nerve anatomy also in the hamstring area. And this plays a vital role in diagnosing and managing complex groin injuries. So in short, what we want to do is we want to unmap the pain to identify its true origin and treat with precision. And one of my key contributions, as you already mentioned, was the identification of the pyramidalis anterior pubic ligament adductor longus complex, or PLAC. And that discovery has, I think, reshaped the understanding of groin pain in athletes. And I've also led extensive research into adductor injuries, developed imaging protocols, state-of-the-art MRI protocols, and also pioneered some surgical techniques designed to support a faster return to play while reducing the risk of recurrence. And in 1923, I was honored to receive an honorary fellowship from the Royal College of Radiologists in recognition of my contributions to musculoskeletal imaging and of the groin area, and my ongoing commitment to innovation in sports medicine. And these are the things that we will discuss in this podcast.
Yes, I mean it's quite a rap sheet, and it's amazing the work you've done and how it's also, you can see it sort of translate down into actual clinical world and getting the information across. So I guess that's what we're here to do a bit today, and we're not going to obviously be able to get it all out there, but really interested to hear, straight from you how you'd work through some of these injuries. So we'll try to be pretty punchy, but I'm going to start with the PLAC, and you've sort of identified or defined what that is already. Your work suggests that an injury to this area is rarely an isolated injury, and you've identified sort of 6 subtypes of a PLAC injury. What types of injuries, in your experience, when it comes to this pathology, require further surgical intervention, and which ones are left better than non-operative?
I think it might be a good idea just maybe to talk a little bit more about the concept of the plaque, basically. We've already explained the anatomy, and it's an acronym that can help clinicians who see athletes with adductor avulsions to look at other structures that are commonly injured, and that means the pyramidalis, adductor longus, and also the pectineus. It all starts a bit with the actual injury. So if you have an athlete who is on the field, he feels a pop in his adductor area, you have to do an MRI scan, and because there's if he feels a pop whilst he's playing, he can't continue playing. That athlete will have an adductor avulsion until proven otherwise. So it makes sense to do an MRI scan. And now the plaque comes. We have 6 different injury types, so it's not a grading system, because a grading system is not appropriate to use for these kind of injuries, because it doesn't it doesn't tell you which other structures that are involved. It doesn't tell you the status of those other injuries, and so the types will actually give you some information. So that means that because of that anatomical connection, we will see, for instance, that in 50% of the cases, the pyramidalis is still in anatomical continuity with the adductor longus following an avulsion. So that means that we will see on the MR that there's less displacement, and so it sometimes leads to underestimating an injury, because you think, oh, it's not much displaced, so it's not that bad. But we can have still a complete avulsion of the adductor longus, but it's held in place and minimally displaced because of the pyramidalis muscle. Now, if you typically for an isolated plaque injury, an isolated adductor avulsion, so a type 1 plaque injury, you'll see that there will be a lot more displacement. But then, obviously, there's a disconnection of the anatomical connection with the pyramidalis. When you have an avulsion, partial avulsion of the pectineus at the same time, you will have less displacement of that fragment, because it's connected to the pectineus, which lies next to it, and you'll see that your fragment is a bit tilted. So it will influence a bit what you see on the MR, and it's actually crucial when we that we do the right imaging protocol, and that's something that we've developed just to make sure there's consistency in the way how you look at those injuries. And we do a 3-step process, and so in you need 3 steps to determine which type of plaque injury that you have. And so the axial, the sagittal views of the pubic area, so the sagittal cuts through the through the pubic area and the adductor longus are very important to, first of all, examine your adductor longus fiber cartilage and see if it's intact, partially torn, or completely torn. And the sagittal view has a bit of an Australian link because many years ago, I think it was about 2003 or something, or 2002, I was doing dissections in Brisbane. So we're doing an anatomy study there, and there we noted that when we were making sagittal cuts to the adductor longus on our specimen, that we actually could visualize that fiber cartilage very well. So thanks to the Australian anatomy labs, we've developed this sequence. And on the sequence, we also have we can look at that connection between pyramidalis and adductor longus, and actually it's not very difficult to look at the pyramidalis, because it's the only muscle that is that sits, and the only abdominal muscle anterior to the pubis. So the rectus abdominis is not anterior to the pubis, and I think a lot of the confusion that we see in the imaging and actually that concept that has been around for a long time, that the adductor longus is in connection with the pyramidalis, is because in athletes don't have fat planes, and because of the lack of fat planes, you can't always distinguish the rectus abdominis muscle from the pyramidalis muscle. But the pyramidalis muscle is the only muscle that sits anterior to the pubis, so it's very easy to assess that connection. So that's step 2, looking at the anatomical connection of pyramidalis and adductor longus, and you want to check if that's intact, partially torn, or completely torn. And then the third step, we look at the coronal views, and on the coronal views we can assess very well the plane in which you will find adductor longus and pectineus, and then we can look at the pectineus and see if there's a partial avulsion or if your pectineus is intact. And usually, as a rule, when you have a partial avulsion of the pectineus, there's also a longitudinal split of the inguinal ligament, and it's actually that fold of the inguinal ligament called the lacunar ligament which is torn. So, and by following those 3 steps, we have the 6 different types. Now, your question is, it's also, from a clinical point of view, it's also important that, people say clinically, if you have an adductor avulsion, you will be able to feel a palpable gap. But in those 50% of the case where you have a complete avulsion, but still anatomical continuity between pyramidalis and adductor longus, you won't be able to feel a palpable gap because there is still that continuity. So you have to be careful by using that and to underestimate the presence of an avulsion, basically. So therefore, always apply that rule. When there's a pop, the player can't continue playing, do an MRI scan and use the appropriate sequences to look at that injury. Now, I think with adductor avulsions, there are still different schools. So there are those schools that say they can all be treated non-operatively, and some schools would say you all need to treat them surgery. I think the truth is probably somewhere in the middle, and what we did, we have a very large series of plaque injuries approaching 500 cases, and looked at over 100 cases that actually had failed conservative management, and I think that it makes sense to do that because it does give you a bit of insight in which injuries don't do very well with conservative management. And for instance, a type 3 is the most common type that we see, not responding well to conservative management, and that's probably because the adductor longus is still in continuity with the pyramidalis, and so you have two muscles that keep that fibrocartilage fragment moving basically, and stopping it from sticking together basically. So that might be the reason why that's a more common type that fails conservative management. So I've seen lots of examples of players that go through cycles basically with this injury, where you have they go through a rehab program, and when they actually get to that last 5-10% of their performance, they have a re-injury, and often it's because they're not able to sprint flat out, they're not able to kick long balls, or they're not able to cross over, and yeah, the difficulty is that we don't know that at the start of the injury basically. So therefore sometimes a more pragmatical approach might be useful, where you say, well, yeah, okay, we if we deal with professional athletes, we go for an approach where we have the highest chance to have a return to play without any issues. So that's another option basically. But so far, I think surgical management is very successful.
Yep. All right. So I guess, do you think, in your experience, and I've just got a case or two in my mind where, what you've reported with the sequence of the MRI, that maybe we're underreporting some of these injuries at times, potentially just rehabilitating an injury that you think is an adductor strain, and do you often see these type of injuries come to you weeks, months down the track, almost presenting as like, chronic groin pain? They've had pain for 4-6 months. They've had that recurrence you've mentioned. And it sort of comes back to maybe missing that initial diagnostics. Do you see that in your practice?
Yeah, so going back to what the PLAC actually explains you, is that we see often that when the longus is still in continuity pyramidalis, that those athletes actually complain about lower abdominal pain, and that can be very confusing, because I've seen not one or two, but dozens of athletes who then end up having a groin repair, an inguinal repair, because of the lower abdominal pain, and so that's quite a familiar scenario for me. So therefore, our approach is when we have athletes who, again, it's that symptom which is crucial. They and I keep repeating it. So they play. They have an injury. They feel a pop. Can't continue playing. You have to do an MRI scan. Now, if that athlete also complains about groin pain, inguinal pain, pain in the inguinal area, then it makes sense to do a dynamic ultrasound, because I feel ultrasound is still the best modality to assess structural abnormalities of the inguinal canal. And we tend to do, in professional sports, we tend to do that routinely for when we have a PLAC injury, because you want to avoid that scenario where a player starts to complain about inguinal pain when he's approaching the end of his recovery. So for that reason, we do a dynamic ultrasound scan. We look at structural abnormalities of the groin canal, which might be bulging, which might be widening, which might be a direct hernia, indirect hernia, or a combination of those abnormalities. And then we tend to do selective nerve blocks. And so with those selective nerve blocks, usually of the lingual nerve or a gentle branch, we can work out if in that athlete's pain presentation there's a component that's inguinal related. And if it is, then we'll always do a groin repair in addition to a PLAC repair.
Okay, nice. Yep. And I guess a common scenario I was going to sort of throw at you, which might step away a little bit from the PLAC scenario here, would be, someone presenting with hip pain, like right anterior hip pain. They've got pain of the abdominal region, maybe a little bit in around the pubic region, so that segmental pain that they're getting from a groin pain. And I know you work with Rowena Johnson with some imaging, who's doing a groin masterclass with us that's going to be released soon. How do you navigate through that? If you can just give us a bit of a step-by-step approach on, I guess, one, how you determine where you think the true diagnostic issue lies. Is it the hip? Is it around the nerves, as you mentioned there, or is it purely just the soft tissue abdominal component?
Yeah, I think we have to be careful in this area to have let's say a specialty-driven bias, and I have that advantage that my area that I deal with crosses over, and I think if you look at US, everything is a lot more hip driven than I would say than that's in the UK and probably in Australia. So I think the key point is that we look at the performance reducing pain. That's the key point basically, and to see athletes with groin pain who have a bit of a mix from different areas is very common basically. But I think what really helps is we do a standard kind of approach usually for groin pain basically, with I would say starting with ultrasound, and you can do some plain X-rays as well, looking at the morphology of your hip joint. Look for cam and pincer impingement. But this is very common in football, well, in soccer. But I would say there's still a small number of professional football players who actually end up having hip arthroscopies, whilst labral tears are very, very common. It's almost I think you almost not see professional athletes signing scans of the hip area without a labral tear. So it's a very common finding basically. I still see in football basically, in sports that it is much more common to have an inguinal issue than a hip issue. And what helps is with your clinical assessment. A very simple test is long lever resistant adduction. Long lever resistant adduction tells you a lot. So it in athletes with inguinal pain, you will see that they have pain on a long lever resistant adduction that will not give you pain with any hip issues. Some simple questions such as pain with coughing and sneezing, pain with sit-ups, pain rolling over in bed already can also give you guidance in which direction to go. But also the nature of the pain is important. So neural pain is usually more ill-defined. Whilst if you have let's say a primary adductor longus endosopathy, the athlete will tell you, here is my pain. They don't have to think; they can immediately tell you where the pain is. But since we started doing the nerve blocks on a very regular basis, so we do it several times a day basically, we've also noted that the anatomy in the inguinal area is can be very different in terms of the nerve nerve anatomy, and also sometimes you're surprised that you might have an athlete with pain over the adductor area, which is ill-defined, and you block his ilinguinal nerve and the pain is gone. So we have to be very careful there. I think it enforces the value of the nerve blocks in trying to unmap the pain of the athlete, especially when you see sometimes distribution of the nerve anatomy that you not really expect. So I think, and that's one of the problems that we might have, is that we have an image in our mind, and that might be an anatomy image of that area, or the nerve anatomy basically. And what we try to do is we try to match that to the knowledge that we have, but not to the knowledge that we don't have. And what we do is we record the nerve anatomy for every surgical procedure basically, and we see that there's a lot of variation in the nerve anatomy. So we see accessory nerves. You can find accessory ilioinguinal nerves, accessory ilioepigastric nerves, and that can all contribute to sometimes a bit of a strange presentation of pain. Now, in terms of hip pathology, basically, I think it's important that a diagnostic injection of the hip is very important before deciding on any hip arthroscopy surgery, because I think I mean a lack of range of motion, and we in football we have all this kind of bizarre things where you have, for instance, your kicking leg might have a bit of more internal rotation, might have a bit more external rotation. So these are things that we can commonly see in athletes, but sometimes we also note that there's some stiffness of the hip on actual testing, that there's a bit of lack of internal rotation on actual testing, and that can contribute to some some other pain phenomena, and something that we see quite often. And I don't think it's actually known or recognized is pain in the more posterior aspect of the adductors, in the area of the adductor intersection, and the adductor intersection is the area where your adductor magnus, adductor brevis, and gracilis join together. And sometimes we see fascial thickening of that area, and that can be a cause of chronic groin pain. I've seen professional football players losing a whole season because of pain in that area. And what the way how we deal with this particular injury is with an adhesiolysis of those three adductor muscles basically. But we've noted that this is always associated with a loss of internal rotation of the hip, and it's subtle. It's an actual rotation. And Rowena, who you've just mentioned, she's developed a technique to do an adhesiolysis of the iliofemoral ligament, and that helps to restore that rotation and also restore that overload that we see on that adductor compartment. But something that we also see in that area is and it's again more common than probably is known is operator nerve issues. And also there we see we see that there is ill-defined pain in the usually around the musculatus junction, and it's usually the anterior branch, the anterior division of the operator nerve, which is involved. And also there we have differences. We have lots of branches. We have branches that go into the gracilis. We have branches that follow the adductor longus, and that also can influence the pain pattern. And then there's also the posterior branch, which is nicely tucked between magnus and brevis, and the anterior branch is between brevis and longus. And the frustrating thing is that nerve conduction studies are not really telling us a great deal, or the imaging is also not very helpful. And so selective nerve blocks of those nerves are actually the key to the diagnosis. But another type of nerve pathology in that area, which I think is very important, is anything related to the genital branch of the genitofemoral nerve. And usually it gives pain around the pubic area or distal to the inguinal ligament, but we see that some athletes also present with testicular pain. And we see often that kind of route they follow. They go and see a urologist. They get a complete urology workup, and then are still left with no diagnosis. And we see those quite often, and it's often associated with inguinal pathology that we see in athletes. It's a muscle that also innervates the cremaster. So some of those athletes, a small group, then will complain about like testicular retraction, and some of them actually mention that when they actually lift their scrotum, that it reduces the pain. So we have those subtle things as well that can help us with our diagnosis. They're not commonly known, and it's also it's often not the kind of question that people like to ask, or also information that athletes like to volunteer. So it's important that it's a standard question of your diagnostic workup for groin pain.
Now, for those looking to upgrade their rehab space and equipment, check out IronEdge. It's the one-stop shop for all your rehab equipment, from hamstring machines to the racks and cages to barbells and everything you need that's suitable to the rehab athlete. So check out ironedge.com. I feel like I'm just getting clinical gold information every sentence you say, and I haven't had to ask more than one question. So it's been amazing, the information you're passing on. For the sake of timing, I could talk to you about groins forever, but we're going to do a big 360 here, and I'm going to fire you away at the very topical topic of the T-junction in hamstring injuries. We had a podcast with Fergal, who I think you've worked with a little bit from a physio standpoint, but really keen to, and I've got some questions that have even sourced from different physios in the AFL football fraternity here. They'd be really keen to get you to answer. And so to kick us off there, I guess, in a newspaper article recently, which was obviously more of a publicity side of things, but you did say there are different types of T-junction injuries. That's what I sort of quoted. And I guess my question to you is, in your experience, is there clear radiological or clinical findings that may hint to you at different injuries that will do well with conservative management, or versus those that you think are more of a surgical candidate? And this comes back to, I guess, that high recurrence rate that we hear about, and I guess we know about, and it's probably still in its infancy around learning it, around T-junctions. But are you seeing a pattern of that? I mean, the subclassification thing with PLAC, is there something that sort of sticks out to you saying this injury is worse than this one in your experience?
Yeah, it's you see different patterns basically, and I personally think that at the moment we are not up to date yet in getting the imaging perf for T-junction injuries. I think it's also important that we not just look at the MRI, but also have dynamic ultrasound assessment. I think is very useful. If you look at you have indeed different patterns basically. I think the one that where you can get away with best is the one with the deep limb of the T-junction, basically the deep fascial limb basically, which sits between the longus and the short and long head of the biceps basically. An injury which is particularly troublesome is the one where you have a distal avulsion of your long head of the biceps, and now again here we have a lot of anatomical variation. So your long head of the biceps can sometimes insert quite distally, and so which means that you have to make sure that when you do your MR imaging that you go low enough, because otherwise you might miss that tip of your T-junction basically, and that distal tip of your long head of the biceps, and you want on imaging, you want that long head of the bicep, you want that to be sharp. if it has lost its sharpness and it's a bit more rounded, I think then we have a risk for recurrence. And it's a bit like a zip wire kind of phenomenon. So it pulls off a bit more and keeps pulls off a bit more until it pulls off all the way, basically. So these ones, I would say I probably have a lower threshold to fix them. And but yeah, as we mentioned, what we see during surgery always looks worse than what we see on the imaging. So and that I think that to me means that there is a lot of opportunity to get a much better imaging protocol, and I think we need to put in some further thinking about which planes that we need to cut that area in to have better, more precise imaging, basically. Yeah, the injury that also can be a bit troublesome is when the tear is actually at the T, when where you have both planes joined together, basically, because there as well you have the we shouldn't forget that we have two muscles with different innervation, basically, and I think that's probably one of the drivers to that injury happening, basically. But going back to that that T junction, I think there's definitely a good role for those for PRP, basically, but it depends a bit on the maturation of your scar, basically. I've seen athletes with tear just at that T, basically, who had PRP, which I think was a very reasonable approach, a very reasonable conservative approach, but then end up having several occurrences, and purely because in that particular athlete's case, the scar didn't seem to mature in a way that it provided stability, basically. So I think, we probably have to avoid that. You go into a scenario in those cases where you think, well, this looks reasonable for conservative management. I don't think you can at the moment. There are that probably fall a bit in the gray zone, and I think when it's really at the T, you can probably discuss either way, but I think doing conservative management there is reasonable, basically. But the long end of the bicep distal tear, that's one I think you have a much higher risk for occurrences, and I think that probably needs fixing.
Okay. Just to clarify, if you were to use PRP, are you saying in that case maybe that player, did they have that intervention too late, or do you think it was just the scar didn't mature for whatever reason?
I think the scar didn't mature.
Okay. Yeah. If I was sending my top athlete from one of the Premier League clubs and it was a primary injury on this, like how often in this sort of scenario over there, just at the moment, like are you operating on primary injuries when it comes to T-junction? I guess the decision might be easier because if they've recurred at 4 weeks and 6 weeks, and in those situations, you probably understand that Premier League where you...
the overall majority are non-surgical. Yeah.
Okay.
But I think if I mean the surgery itself, I guess you want to chat about that as well. Basically, is relatively straightforward, basically, and the return to play somewhere around 11-12 weeks, basically. Now, as with I'm as you know, I'm primarily a soft tissue surgeon, basically, and soft tissue balancing is crucial, and so that means that you have to avoid that you over tighten, for instance, and so you have to make sure that you that you take care of that, basically, because if I pay a lot of attention to that, so I don't really see any issues with that post-op, but I've seen a number of athletes who had T-junction surgery who had over tightening of that of the T-junction, basically, we then present with issues of your distal biceps, and that might be longitudinal split or significant scar tissue. And so scar tissue is always can be an issue as well, and so we've seen a number of athletes with this particular issue post-op, and for which we've done ultrasound guided adhesiolysis and PRP of longitudinal split of the distal bicep, and that usually settles things.
Now, I guess I'm going to have another question around the surgical side of things, but just, I guess, swinging back to the imaging and post-injury, potentially MRI at the moment can maybe undercall or not give us all the information, and you recommended, obviously, the use of ultrasound. If and we actually chatted with Fergal around this in the other podcast, where there might be some use of some dynamic ultrasound as almost a tracking process to have a look at this scarring and seeing if things are healing up. Do you advocate for that as well, in the sense of like, okay, this is not responding how we would expect, and it's now 4 weeks and we're not actually getting, showing good signs, we might opt for surgery in that case? Is that something you utilize with your athletes at all?
Yeah, we tend to follow ultrasound for scar use ultrasound for scar maturation, to look at scar maturation, because MR is much slower on that than ultrasound. So but the problem is that one of the problems with T-junction injuries is that often they have very little symptoms, and so they have their injury, and a couple of days later they feel great. So they go through a rehab program. Strength is great. They can sprint flat out. They tick all the boxes that all the markers that are routinely used, and plays at 4 weeks and then re-injures. So it's I think because of that it makes sense that you give imaging a better position, and actually use it as part of your routine check, basically, because we can't just purely rely on the athlete symptoms alone and testing because of what we regularly see in terms of patterns. So therefore you need to take a bit of an approach like, with the T-junction injuries, it might be better that you give them probably about 6 weeks. So just giving that a bit longer. So we need to learn also from what we see in terms of recurrences, where you say, well, okay, fine, we've ticked all the boxes basically, and now we have a re-injury. So I think that's important as well, basically. And so yeah.
Yeah, you mentioned 11 to 12 weeks from a return to play, give or take, from a surgery. There's different reports sometimes of people around 8 weeks, 9 weeks. I guess, what are your recommendations to your athletes or the physio guiding that person post-surgery? Do you have certain things around time to run, or is it more around time to load that would stress that tissue? And what if I was to saying we're going to get an athlete back around 8 to 9 weeks? How does that fit with you? How would you feel about
that? I mean, there always those athletes are quicker than what you plan, and the only person feeling uneasy with this is the surgeon, not the athlete, I guess. I think that you work to, I mean, for instance, if you work to progress for running, basically, you want to make sure that athlete's flexibility is fine, and then in preparation of running, you can start with high knee walking. You can do high knee skipping. You do that over short distances, to not to risk to avoid risking injury, basically, and so you do that kind of progressive program, basically. Something that I get a bit more focused on as well is actually strength, and I often see players coming back and they say, he's now his strength is now 130% of what it was prior to the injury. and that makes me feel a little bit uncomfortable, because I think perhaps maybe nowadays we're too much focused on strength rather than trying to get an optimal strength for that athlete. So if that athlete's strength was X before, why shouldn't be X after? And he has that symmetry basically. I don't want to revert back to adductors, but I went through a stage where, and I've been in the adductor business for a very long time, for over 25 years, and so we went through a stage that we thought, well, we have to make them as strong as possible, and then you see that athletes were starting to get some discomfort over the adductor insertion, because they were actually loaded to an extent that they're not physiologically built for. So therefore, we revert back to a concept which is very commonly used, which is the ratio between adductors and abductors, and we use that. We aim for that ratio rather than trying to go crazy with strength, basically. So therefore, I prefer to take that approach rather than being completely focused on strength.
Okay. Yeah. Like it. Now we're going to get you off to theatre in a second. I've got a sort of final question to throw at you. Look, the T-junction in the literature recurrence rate, it varies, I think, from anywhere from 40 to even 70% in some cases, when also the higher grade ones may fail, and that's probably where things are sitting at the moment. From a surgically intervened case, do you see most of the surgeries are just a clearer path? Have you had many that you've done have still recurred? And if they have recurred, has that been at the site of injury, or has it been more, as you mentioned a bit earlier, more distal or proximal to the site?
So far, it seems to be a very straightforward kind of surgery in terms of the results, basically. Until now, touch wood, I haven't had any re-injuries with the T-junctions, basically. But I think a lot of it has to do with the soft tissue balancing, so that's why it's important not to over tighten them, and obviously your T-junction, if you don't want to extend repair beyond your T-junction, basically, because then you risk that, then you have that risk of over tightening, basically. So so far it seems to be pretty straightforward, basically.
Beautiful. Well, Ernest, mate, it's been
maybe let me add one more thing, basically.
Oh, please do.
So it might be a bit of a simplistic kind of thought, but at the end of the day, tendons, they are elastic bands. They're kind of elastic bands, and if you stretch on them quite a lot, basically, then they lose their elasticity. They become what we call the plastic deformity stage on the Gauss curve, basically, and then they might not be able to absorb energy the way a normal tendon does, or a healthy tendon does. And I think that might be part of why we see injuries occurring very often with a player goes for a jog and he ruptures his hamstrings, basically. So I think it's important that with our strengthening, that we maybe if you do a lot of strengthening at maximum length of the actual muscle, then you might lose that elasticity. But I'm a big fan of listening to certain signs, and when you hear a pop, it's usually free tendon, basically. If you have a tendon tear which happens intramuscular, basically, then you don't hear that pop. It's like shooting with a gun with a sound damper on it, basically. So that also will the absence of a pop doesn't mean that it's not necessarily that it's not a significant injury. It will tell you something about the anatomical area where the injury takes place, and if it's intramuscular, you don't hear a pop. They feel often a ripping sensation, basically. So that was my last comment. A bit of biomechanics.
No, a very good, nice way to finish, because I think obviously most of our listeners would fit in the physio and the rehab and camp, and I guess what might be one of our biggest roles is just restoring that elastic energy, reducing the strain where we can, and finding optimal ways to do that. And that's obviously a lot of the work that gets put in by a lot of people to try to advise on that. But it's ever evolving, so it's what keeps us curious and interested. But as I said, you're off to theatre. It's really grateful to have you on this for a chat. We've loved your work. We've followed over the years, so it's been a privilege to have you on.
Thanks very much. Privileged to be here.